So welcome everybody. It is Friday, May 30th. The year is moving on quickly. We have today an amazing speaker, a very close friend. So Chief Charlie Coyle was my chief of EMS at Palm Beach County Fire Rescue, and now he's been moved to the Health and Safety Division, which he's done just some incredible work. And today's topic is very important. It's probably something that many of us have not thought of, but of course, Chief Coyle came in and he made this a priority. And this is something that I think all of you will hear and say, yes, this makes a lot of great sense, because it's really looking after our own. So great topic. And I want to introduce Chief Charlie Coyle. So Chief, if you want to make any further introductions, and take it away, my friend. Thank you so much for joining us today.
No, I just want to say thank you, Peter. It's an honor to be on here with you and the team, but it's also an honor to work alongside of you for the past 10 years. And if there's one thing I've learned from you, is really how to take care of people. And that's exactly what we're going to talk about today. And I might be the one giving the talk today, but I just want to let you know that this was done by a lot of other people. If you look at this front cover page here, it almost looks like a NASCAR with all the endorsements on it. But in all actuality, the Palm Beach Sheriff's Office is involved with us. The Florida Fire Chiefs Association of Palm Beach County is involved in this, and I'll explain their purpose of the event, or of the project. EMS Providers Group of Palm Beach County. Obviously, Palm Beach County Fire Rescue have had great support from our fire chief as well as our union president. And then Delray Medical Center, and they have been absolutely phenomenal. And I want to tell you each and everything that they did to help us get this started. Let's see. Last week was EMS week. And if you look at EMS week, there was a slogan for the year, like they do in every other EMS week. But the slogan was, "We care for everyone." So rhetorically, I just want to ask the group here, basically, who cares for you? So we have a bunch of first responders on the call today, or on the video, or watching the video. We have a bunch of ER physicians, medical directors, but who takes care of us when we're in crisis? We do such a good job with everybody else, but what is that next step for us first responders? Well, the gentleman, the good-looking gentleman, the bald one in the picture here with the arrow over his head, he is our peer team coordinator, and this is us in the streets of New York. And basically on the streets of New York, we were at the symposium, the IFF host, the Redmond Symposium. And basically, that's when I started learning how to take care of other people that do the job. But day by day, Steve Newell has taught me more about how to take care of our people. And he's actually the one that brought me this concept. I did not come up with this today. I made a couple phone calls and brought people to the table, but this was strictly Steve's idea to bring everyone to the table, to have a conversation, to create a track specific for first responders. So I'll just go over some loose definitions for the day. I know that we're going to talk about Baker Acts, but when you're giving a presentation like this, Baker Acts sometimes could kind of turn people off to the topic. So for crisis, we're going to say mental health crisis. When we talk about assessment, we're going to talk about mental health status. When we talk about response, early notification to the receiving facility, if there's anybody that knows how to be an expert in that category, it is EMS, right? We encode every single patient that we bring to the hospital. And then engagement. I'm going to talk about how local mental health professionals need to work with your local peer supports, because there are gaps in that. There are gaps in hospital care that your peer support teams in your department can bridge for the community. This program is offered for active and retired personnel. Now, I gave this educational session to some of my firefighters during this week, as a matter of fact, Tuesday, Wednesday, Thursday. And I told them, I said, listen, this isn't like the Marriott Bon Voyage where you got to have your ID number or a retina scan, or, they don't have to tell you when they served. It's very simple. If they participated in service as law enforcement, corrections, fire department, EMS, military, hospital staff, we want them under that first responder umbrella. The dispatchers, they get forgotten all too often. And then Department of Justice. So basically, and here's the take home, active or retired. Because for some reason, we think that when we get off the job, all of the stuff that we saw goes away. And the more I learn from retirees, that is absolutely not the case. As a matter of fact, they get into a situation where every single day is structured for them. Their uniform is structured. Their task for the day is structured. Their connectivity to the community is structured. And that well-being, being next to other firefighters, is connected for them every third day. And then all of a sudden they retire, they're kicked off their emails, they don't have the correspondence, they don't have the dinners with their team anymore, and they're left to think about all the years they serve. The coolest part of all of this is Delray Medical Center has agreed to do the same exact procedure when somebody falls under a Marchman or Baker Act in their hospital by asking them if they were a first responder plus. The reason why we call the program First Responder Plus is because we've added more people under that umbrella, as you can see listed on the slide. I wanted to go over some statistics, and I know Tanner's getting excited already because we're talking about studies and the graphs, but basically there's a couple of things that have been published on this topic before. And I went all the way back to 2006 to start finding some of the literature. Well, the interesting part that the University of South Florida published was from 2004 to 2016, Florida recorded 7,128 deaths ruled as suicide by the medical examiner. Out of them, 1,147 individuals, 16% of them had undergone at least one involuntary psychiatric exam within 4 years prior to their death. So that's 16%. But when you look at that 16%, if you look at the first 180 days, 34% of them committed suicide in the first 180 days after that psychiatric evaluation. So let's look for a more modern study. Let's look at a bigger study. This was a meta-analysis. This was a total of 34 papers put together. 29 reported the suicides in the first 30 days. 24 reported suicides in the first week. And the conclusion of that study was, I'll read it to you specifically. In the month after patients leave inpatient psychiatric care, their suicide death rate is 300 times higher in the first week and 200 times higher in the first month. Furthermore, this was a document that was put together, a task force, a suicide task force, essentially, that was put together by Governor DeSantis. And there were some strong statements in there. Here's one of them. First responders are 1.4% of the Florida's workforce, yet their suicide rate is more than 2 times higher than the overall rate of working age Floridians. Furthermore, we found a couple of suggestive processes, like basically bringing the first responders in a separate door, maybe mixing up their name in the system so you can't find them. But there was no from when you get on scene to when they go home and follow up care. We have not found a process to support this population yet. And these are the suicide numbers. And I got to tell you that there is some legislature going through that I'm going to talk about in a second that's going to make it where we're mandated to report these things. I believe these are anecdotal numbers and extremely low because of the way the reporting system is. Furthermore, the National Fallen Firefighters Foundation, a fire department is 3 times more likely in any given year to lose a firefighter to suicide than a line of duty death. So when you look which groups of first responders fall into that category, where EMS is the highest, basically your dual firefighter and EMS, 49. That's most of the departments down here. Firefighter alone, 58. Law enforcement is 42. And it's interesting with law enforcement, by reading about this, law enforcement has a pretty strict policy to get hired as a law enforcement agency. So they do lots of psychiatric evaluations. They've now moved on to some resiliency screening before they hire people. So, I mean, just thinking out loud, I do believe they're a little bit more selective in who they bring onto the workforce. And I do believe that benefits long-term, long-term risk, honestly, of seeing things and being able to deal with things. But if you look at the graph on the other side, it goes all the way up to the ages. And right in the peak there is 35 to 54. But if you look at 65 to 74 and over 75, that's not that low of numbers. So you are not safe when you retire. And that's why it's important to have places and progresses. You have to have a system in place, an ecosystem for your retirees. Believe me, they still want to be connected. The hallway of shame is what I like to call it. I challenge any of you to tell me I'm wrong on this, but I want to think about your time when you've transported someone to a hospital or you've done an ER shift in a hospital. And I can put you in any hospital anywhere in the United States or even internationally, and I could walk through the ER with you and say, do me a favor, point to me where the Baker Act is. And right away, you would look down the hallway, you would see the person sitting on the wall in probably handcuffs and having the worst day of their life. So imagine this. Here is the worst day of your life. You've served your community or your country for so many years, and now you're in the hall of shame, passing by the people that you've served with in the community for over 25 years. There has to be a better way. And I say the time is now. There is legislation now, House Bill 929, that is on the desk of Governor DeSantis, and it talks about a few different things. But really what they're looking for is best practices, and they're looking for the agencies that are struggling. They want to figure out what are the best practices to stop this suicide phenomenon. How do we make it better? How do we provide toolkits for them? That's what this House bill endorses. So to me, a program like this could come at no better time. So how do we make it? How do we put it into action? What's a pragmatic approach? How do we make this simple for everyone to digest? I think it's pretty simple. What we came up with is determine if a patient is a first responder plus. So this has to be done not by just fire rescue, but law enforcement, because law enforcement transports a lot of these people to the hospital. So the goal is first to ask your patient if they're a first responder plus, if they're going through a voluntary or involuntary Baker Act procedure. Next, Delray came through. Delray Medical Center says, we're going to give you the phone number directly to the nursing supervisor. And we put it in all of our phones for Palm Beach County Fire Rescue, all of our work phones that we have. And basically what they would do is they would call the ER, they would call the nursing supervisor. The nursing supervisor will ask a couple questions like an end code, and they will be ready when we arrive. The nursing supervisor is going to meet the first responders right at the front door. We're going to go in through the same entrance, but we're going to bypass registration. We're going to get into the behavioral health ED pronto to keep them out of the hallway of shame. And then I think one of the most important things with this is we're going through the process now of collecting everybody's peer support contacts. And I'll give you an example. If we transport in Palm Beach County a firefighter that works in Coral Springs, and we take them to Delray Medical Center, at the employee's consent, at the hospital, Delray would have the peer support number for Coral Springs. Delray will reach out not to their administration, but only to their peer support. And then peer support would be able to help take care of their employee. This is the flow chart for Delray Medical Center. Like I said, from the beginning when we went to Delray Medical Center, Heather Haverchek, the CEO, was at the table every single time. She had her staff there. She had psychiatry there. She had the nursing staff there, the medical director staff. It was a packed room for the 4 in-person meetings that we had. And she walked through every part of this herself with us. But essentially, the crew would call it in. They would get in touch with the nursing supervisor, like we already said, a brief encode. Staff would meet us out front. Then the next part would be we would move towards the behavioral health ED. If the patient is a medical patient and requires more care than what the behavioral health ED can provide, they will have their own private space in the hospital to receive medical care, medical treatment, and clearance, coordinating with psychiatry. Because I can tell you that this is not seamless. We think it is, but it is not. We've done in-service with all of the staff at Delray Medical Center to teach them about peer support and the importance of it. So basically, they understand what peer support is. They've helped us craft a consent form, and they're 100% in on doing this. Furthermore, they're going to have a consult from Fair Oaks to provide inpatient care if necessary in their psychiatric ward if needed. So I've already told you a little bit about peer support, but I think this is a very important statement here. It says hospitalization is not designed to be the only treatment that patients need to restore them to wellness. That is where peer support comes in. That wraparound service we're saying should occur for a minimum of 180 days. However, when you talk to these peer team coordinators or people that work on the peer team, it's really person specific. They can deal with an employee for 2 weeks and the employee is better and doing great. They can deal with an employee for 2 years and have to call them every single day. These men and women that serve on these peer teams are selfless individuals. It's all usually voluntarily done. And they are just incredible people that have one goal and one desire, and that's to take care of people. So what do you need to get this started? Because I truly believe that everywhere in the state of Florida, I believe everyone in the world should be doing a program like this, but really it's the willingness of your law enforcement and your fire department. You've got to train the frontline personnel. We're going to do a training video next week on this, and we'll share with everyone. You got to create a policy, SOG, or a memo, or put it in your protocol book. For us, it's going to be a memo that comes out next week, but basically it's going to land in the protocol book after that. And then the crews have to ask the question, are they a first responder plus the patient? Contact their dispatch center or the nursing supervisor directly. And then we're going to say the patient is a care alert, because that's what this is. This is a care alert, no different than a trauma alert, no different than a sepsis alert, no different than a STEMI alert. And then just provide the wraparound information to Delray Medical Center. So we did a couple of scenarios. We wanted to do a walkthrough to make sure that we had everything dialed in. We did a patient that basically was a medical patient, and then we just did a patient that was transported by law enforcement. And this is what we found. So this is your main entrance to Delray Medical Center. The staff's going to meet us right there at the entry. We are going to bypass registration. We're going to go down the hallway to the basically your behavioral health ED right there. The X is going to be where we drop off the patient, so the stretcher doesn't go in there. If the patient's on oxygen, that is a concern for them. And what I tried to explain to Delray is sometimes we have people that look like they're on oxygen, but really we're just measuring capnography. So please make sure that we don't exclude somebody from going in there, because we're looking at their capnographic waveform. So that was a learning point for all of them, and they said no problem, they understood. And then this is what it looks like in the room. This was actually during our scenario. You can see psychiatry's in there, and he's talking to our actor. This is one of our employees, but he is not going through a tough time in his life right now. I'll give you the disclaimer. He was just our actor, and he photographed very well. So we were able to take the picture. But this is what that looks like. For us, they would be calling our peer support and our crisis line directly. That way, our peer team coordinator was the only one that handles the phone call. But why is that important? Because when you start talking to the hospital staff, they don't know all of the treatment centers and specific treatment centers that exist for fire rescue, law enforcement, etc. So for us locally, you have the Second Alarm Project, right? You have the UCF Restores program. We have direct access to get to them and get somebody enrolled. Furthermore, IFF Center of Excellence. I can tell you our peer team coordinator has got somebody into that facility within 6 hours and up to Baltimore within 24 hours. That is why having the experts involved is important. Furthermore, in our area, we have a clinic with psychiatry services. And then, of course, the Hanley Center, again, is in our area, and it has a track specifically for first responders. So the take homes here, early recognition of the first responder plus, make sure you get to the hospital staff as soon as possible, fight for a private area in the hospital. Damn it, we deserve it. Rapid medical assessment and psychiatric evaluation is paramount. Get your peer support involved only with the patient consent. And then make sure you have a wraparound service. It's really important to follow these employees because we know they're at a high risk of suicide afterwards. So I leave you with three things, as a matter of fact. Number one, here's a picture of the scenarios that we did the other day. If you can look next to me, the only lunatic wearing a jacket out, on a summer day. Right next to me on the left is Heather Haverchek, the CEO. I just want to thank her and the entire staff. I saw Elijah was on the call. I don't know who else from Delray's on the call, but thank you for being here. And then the QR code. In the QR code, I have all of the papers that we researched this topic on. I also have this PowerPoint presentation specifically. And then I want to thank a few more people. Number one, I want to thank my fire chief. I don't know if he made it on the call, but
he's on. He's on.
He really let us step out of the box here, and he constantly allows me to operate in these awkward areas of bringing everyone to the table and doing something different. So him and the union president, I want to thank them. Number two, I want to thank the Fire Chiefs Association. The one thing I didn't mention is the Fire Chiefs Association now has a standard operating guideline for every fire department in Palm Beach County to participate in this program. That is huge. Number three, I want to thank Delray Medical Center. Again, I can't say enough about them. Number four, the Palm Beach Sheriff's Office, the PBSO group has been amazing. They're going to be the frontline providers out there with us participating in this program. And then I served our community, our country at any you deserve it. On the worst day of your life, you deserve a little bit more than what we normally would have given. So it's an honor and a complete, distinct. I can't even describe the words what an honor it is to talk about this topic. So I'm open for questions. I know Steve Newell is on the call, our peer team leader as well, and I just want to personally thank him. So Peter, I think I've said enough, and I'm open for whatever conversation you got.
Charlie, that was an amazing presentation. I love the fact that you're focusing on our personnel. We've all been through too many funerals. Your passion for this topic and your leadership and your drive to make sure that our people get taken care of is it's just incredible. I love to see it. Before I get to Dr. Lee, I do want to bring Steve in and even Chief Kennedy. So Steve, Charlie called you out here a couple of times. And you've done a lot of great work, and we want to give you your time to shine. So please unmute yourself and make any comments, my friend.
Thank you for having us. I think this is a really important topic. Having, experienced some of our people get Baker acted and seeing what they go through, having some personal connections, I knew we could do this better. And Chief Kennedy's support, along with President Newsom from the union and Chief Coyle, just really made it everything I could imagine and more.
So tell me, Steve, just real quick, just so everyone can have it, because you've seen things that we will probably never see, which is you see that end of it where people are needing help and they're needing to get help. If you can just describe some of the, and maybe not go into detail, but I know you've probably seen this go sideways, right? And if you can describe why it's important to not let it go sideways for our personnel, because what the negative outcomes of it going sideways can be. Can you give us some like inside baseball on that? Because it's hard to, at least for me, to conceptualize how this can really go wrong, right?
Well, I think with this program in place, our hope is it doesn't go wrong, but I have seen it go wrong where there isn't support on that wraparound, right? So we're going through the worst time of our life. We've already decided that, our social network isn't there for us. It's not something we can rely on. We're a burden to that social group. That thinking has taken over, and we're very introspective, and all we can see is the troubles we have. And when there's something available there's someone checking up on, and there's somebody helping you get to, getting out of bed is difficult. Getting and making appointments for your doctor, to see your psychiatrist, to have some talk therapy with a clinician, those things are just these huge burdens. And when someone's there to assist with that, when someone's there to encourage it, to help it happen, to physically drive, any of those things just help someone in their darkest times. So having that and having that wraparound and the ability for the great people like at Delray Medical Center and Behavioral Health ED have the ability for them to know and connect with the resources that are outside so that it's seamless. There isn't that lag. There isn't that time where bad things can happen. It's crucial.
Excellent. Very, very well said. Chief Kennedy, I'm going to get to you in a bit, but I do want to get to Dr. Lee. Dr. Lee, you've been in EMS for a long time. You've done the hospital and the ERs for a long time. And I know that you've mentored and helped a lot of people, me included. Love to hear your comment.
Well, I have more questions, Dr. Antevi, than comments. I was involved with Florida college when we actually incident review and so on and so forth, and we spread that throughout the state. And I think that worked for a while, and then it sort of fell apart. It was hard to get the various people involved, etc. But Chief Coyle, first of all, I want to say, Chief Coyle, thank you so much. You've been such a treasure to EMS, in South Florida. And you and Dr. Antevi together, it's very. We're all very. We've all been very lucky to have you. Let me ask you something though, and it's funny. Yesterday, every month or so, I make the rounds with Chief Sitnick, and we go around to each one of our reservations, which is a long day. And we do an hour or so around the table, sort of blah, 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 what's going on, where we're going, etc. And it's interesting. We spent yesterday most of the hour at one of our stations on this issue. And Chief Pratt, one of our battalion chiefs, is on the line too, I think, and he's actually heading up a mental health initiative with our team. And so I'm so glad he's here. But let me ask you something. What I'm struggling with here, I think this is great. But if you take the whole picture, it looks like to me you can divide it into two parts, and that's the post-crisis part. And let's say, for all practical purposes, post-Baker Act or post-Marchman Act. And that is what this addresses. What I'm struggling with, frankly, well, I'm struggling with both probably, but what I'm struggling with also is the pre-event, and that's identification. It's after action interviews, after some significant event. We've had recently two babies that have died, and so that's the part where I'm struggling. I'm not sure what to do or how to do it. There's some literature that even suggests that doing that makes it worse. It makes people think about it, focus on it, so I'm a little, afraid of that. I'm not sure who should do it. Even if we did have an after action and let's say an after event, I'm not sure who their peer team would be and who should they be and how do you qualify them? So there are a lot of questions there, but my focus right now is on let's call it pre-event. All right, does that make sense to you?
No, it makes complete sense, Dr. Lee. And first and foremost, thank you for your kind comments. I mean, you're a legend you're an iconic person in EMS, and we all look up to you. So hearing those remarks from you, it means a lot to me. So, I'll tell you briefly, because I know there's probably a few more questions, and we can talk offline, and I think we should, because I want to get you next to Steve, because Steve can answer a lot of the questions about when and how to do the debriefings after the event. I think that has changed. That CISM has kind of rolled away. Peer support has now come to the forefront. And I think that it's optional. I think it's an optional time. And I think that there's, the supervisors, their awareness needs to be paramount. But for these cases here, I can tell you that I've dealt with one of these cases, and it did not go well in the hospital. It did not go well in the ER. The discharge was quick because they wanted to help him because he was a first responder. And really, we should have held him. He should have stayed there. We should have had a plan thereafter to get him to the next place. So, there's lots of things that can slip through the crack, and just putting him in a private place and really spending time with the ER staff. This ER staff we worked with the other day, they had a patient that was, basically they needed to do the last rites. They needed to do an invocation with the patient. And they called us at 10 o'clock and said, hey, we have no one to pray for this family. Can you send your chaplain here? And we did. Our chaplain service went there. And the reason why we did that is because if we can operate with them and communicate good with them on blue skies, when the gray sky event happens, everybody knows everyone. And that just doesn't happen. We don't have the correct partnership with our hospitals. And we have to break down those barriers because everything else opens up after that. And that's just my 2 cents on that.
Good. Thank you. Chief Newell, I'll reach out to you. Okay.
Yeah. And I'll come to you, Charlie, in a minute. I mean, but Wayne, I really like what you're saying, which is that the actual event is the event of the Baker Act itself.
Yeah.
But then there's another event that happened that may have led to the Baker Act, which is the pre-event, whole nother ball of wax, difficult, peer support, etc. And then there's the post-event, which is what Charlie, yes, I do agree. Those are two different arms, very important ones to focus on. I'll go to Charlie, and then I'll go to you, Tanner, after that. Charlie, go ahead. Dr. Ingram.
Yeah, it's okay. I'll be Charlie under Chief Coyle. Absolutely. Yeah,
hey, buddy, how are you?
It's so good to see you. But I love what you guys are doing. It's so important. It's interesting because there's a couple comments have come up kind of throughout, and we're this project that you've done so successfully so far. It looks like it is very focused around a post Baker Act or a post kind of issue that is already happening, right? And so it's, I think that we have an opportunity still across the disciplines between fire, EMS, hospital staff, residents, surgeons especially, et cetera, to like figure out what our screening process is, right? Like we have these terrible things that happen to us and we can't quantify them, right? And I don't know if you discovered in any of your research the type of term like a second victim syndrome, where like we are the second victim of every bad thing that we see, right? And it is super, super common. And without like a self-identifying and I raised my hand saying that was shitty today, there's no way to screen for that. And so we started looking at options when I was faculty at Yale for surgical residents and emergency residents to say like, how was this bad experience for you today? And it turns out that there's a bunch of like validated surveys that nobody really validated. They just said, this is the validated survey. And then they validated it with a study off of their own survey. And I was like, okay, cool. So that didn't really exist. And so we came up with something where we're like, okay, well, what if it's just like a single question survey on like a simple happy face scale? And so that's kind of where our project is now. And they're continuing at Yale, and their focus is for residents because they have problems with residents speaking up about their own mental health. Like until a resident starts crying in the corner, we don't know that they're struggling, right? And so this is the same, right? Like no offense, but firefighters are very similar to physicians and surgeons in this aspect where like they're tough and we keep going and that's just what we do for our patients in our community. But we need to figure out a system to say, okay, that was bad. Let's screen and let's get them connected to our peer support team before they get even close to Baker Acts, before they get to this kind of down this spiral. And this program that you guys have created is phenomenal for picking them up out of the spiral before they hit the bottom. It can keep them from going into the spiral. It's the same thing. And I don't have an answer. I don't.
Yeah. But I don't think, Dr. Ingram, first of all, thank you for all the work that you've done. It's great to see you, and it's great to hear your comments on this. And I would love to see what that scale is and talk about this more. But I can tell you, when we look at this, we also got to think about the people like my peer team. I constantly want to know how they're doing because they're dealing with all of these emotions of all of these people, and there's really no scale to evaluate how are they doing too. So it's definitely something needed. I love to talk with you more offline about this, and maybe we can.
Absolutely.
Yeah, I would
And
love
actually,
to.
Do it over 9 holes of golf. I love it.
there you go. There you go. And I'm going to come to Tanner next, but I will tell you that, I've been following the AI thing very closely. And I will tell you that's the next boon in mental health care is imagine getting a phone call from an AI. It turns out people will tell an AI a lot more than they'll tell a human being. And so these check-ins by text, by phone call, and it'll all be automated. And then Steve will have a dashboard that'll say, check in on these 5 people today because they had some bad calls and they've actually told the bot that they don't feel well. But anyway, I think there's a lot more there. Let me go to our data scientist in-house, the smartest person I know, Tanner 𝐁𝐮𝐢𝐥𝐝, who, by the way, just got married. Tanner, congratulations on your wedding.
Thank you.
And yes, we're very, very, very proud of you. And we wish you many, many years of happiness together. But go ahead.
Sure. Yeah. So I was just thinking, so in our state in West Virginia, our EMS system is comprised of a bunch of small, poorly resourced EMS agencies primarily. And so there's been a lot of discussions, how can we set up systems like this? How can we address mental health, right? It's typically coming from the Office of EMS. The state wants to get involved and do something, and that's kind of where the funding is, and that's where the motivation is primarily. And so kind of coming off of that, right, there'd have to be some kind of determination at the state level, right? How many people do we have to hire? What kind of census are we going to be expecting for this sort of program? And so, I don't know if based on kind of historical precedent, how many EMS clinicians or people in the kind of category that you set out for us, how many of these patients do you project to see in a year or a month or however you've calculated it?
So Tanner, the interesting part is when I asked we have 2 Baker Act receiving facilities, just to give you an overlay of Palm Beach County. And what we try to do is only take Baker Acts to those facilities so we don't put our local ERs in harm, right? Because they don't have the resources to manage these patients. So from safety perspective, we only go to those 2 facilities. Interestingly enough, when I asked those 2 facilities, how many first responders do you actually see as a Baker Act? There was no database for it. So basically what Delray has agreed to do is obviously de-identified is basically when the patient comes in, they will be finding out the age of the patient, obviously, you know, in a subset of data, as well as the profession. And are they active or retired? How long did they serve? That way we can start putting this together, Tanner, and figure out, number one, what is the greatest probability? Like, what branch are we having the most problems with? And then number two, how many patients are coming through in these crises? I mean, I know we've had a couple. I know we've had a few of our employees' family members, their children be Baker acted. So this isn't for them, but reality is we don't know those numbers yet. So Delray has agreed to continuously work with us on the data. I know your ears are probably perked up on this, and I would love to talk to you. We could do a project on this.
Yeah, no, great.
No signatures.
Right.
And you know, I think, Tanner, what you're getting at is something very important, and the analogy that I would give is drowning, right? So we know that for every drowning death, there's 3.5 hospitalizations, there's 4 ED evaluations, right? So, you know, how do we extrapolate from the total number of bad outcomes to the total number that Steve is seeing before they even get to Delray or the other Baker Act Center? And so, Tanner, are you asking how much money should the state, you know, give a smaller rural entity based on these numbers, and kind of trying to figure out what these numbers are? Is that what you were trying to kind of calculate backwards?
Yeah. So I'd say, if I was a state entity and I wanted to have a statewide program for this, right? How many, peer support specialists do I need to have on staff? Like what is the maximum caseload for one of those clinicians? It is more of what I was getting at.
And Tanner, there's so many different things, like there's so many different systems that are out there. But one of the things that we did here a few years ago, and I think that it's very important, is putting the employees in front of a clinician. This is something we negotiated through our union contract. And every year they have a behavioral health screening. So you're able to see deterioration or, positivity where they're getting better. So there's that component of it. Steve's team does about 26 call outs, 4 calls, like actual incidents. They average right about 26 per year. That's very little when you look at the amount of calls that we run on, but they receive a lot of phone calls. They receive, hey, listen, I really need this, or I'm going through crisis. I needed to get into a treatment center. I mean, and I just don't know the number. He knows the number to all this stuff. I just don't know the names, and I never want to know the names. I want it to always be confidential, so our people have a safe place to go within. I work hand in hand with him, but I refuse to get the names. But I do have some numbers for you, Tanner, about how many phone calls they take. And basically, when they take the phone call, they list what the issue is. Is it stress? Is it bad call? Is it alcoholism? So I got data for you, Tanner, that I'll share with you, and you could start to kind of try and construct it and see if it's helpful at all.
That would be very interesting information. Steve, any comment on that? Because so for example, we do about 160,000 calls a year. We have about 1,500 medics. Ballpark, how many calls or inquiries, whatever you want to call them, are you getting, let's say, a month? Or, is there a ballpark?
Well, it really varies. There's so many factors involved. We're doing station rounds right now. I was just at a station and I got 2 referrals right there.
Oh, wow.
I had two last evening, but then it might be quiet for a few days. It's really kind of a ebb and flow. It's really hard to give those exact numbers. The way we kind of quantify it is by contacts, not by individuals, because we're trying to keep that individual protection so that we maintain the confidence to be confidential.
Right. And Tanner, I see that Chief Kennedy dropped off, but I also...
Yeah, he had to get to a meeting. He just sent me a text. He said, thank you, though. He said, thank you for hosting this and highlighting, this work.
No, absolutely. Well, I tell you what, the other thing I wanted to mention, just to go along the same topic, is what Chief Frank Babinick, who then became the city manager, who then now retired, he had a great idea to save money. And what he did was he actually hosted I think a 2 or 3 day course for these clinicians who had their own private practice in the community. Mm-hmm. He brought them in, he put them in bunker gear, they cut open cars, and out of, let's say, the 20 who showed up, he said, how many of you want to become clinicians at Coral Springs Parkland Fire Department at no cost, right? Mm-hmm. They 3 of them or 4 of them raised their hand. He gave them the uniform, the patch, the whole 9 yards. And then they start coming around like Steve, and they're doing station rounds. And now everyone's like, oh, Sean is part of our organization. But Sean just has a practice outside the organization. But now Sean is now getting and becoming an expert on the pre-hospital environment and first responders. And it, at the end of the day, it didn't cost the fire department anything, but we have now a cadre of people that actually wear the shirt because they're part of us, right? Mm-hmm. And so it was so smart because, and Steve will probably tell you this, that nobody wants to use the EAP and get in touch with somebody who has no idea what's going on, right? They want to talk to Steve or somebody like Steve who actually has been in their shoes before. So, Steve, and any comments on that, on having people at the department who people feel comfortable talking to?
Hey, Peter, it's Brett.
Hey.
Once again, Charlie Coyle never ceases to amaze me at what he is the capability to do. This is vitally important. We started our own peer support program a long time ago for the mere fact that, every time we have a significant event at my department, I get a text message. Hey, it was a pediatric code. There was a mass casualty that wasn't out. Something bad happened. And I typically go and I text message my team members. It's a 2-second thing. Hey, I heard about what happened. We'll look at the call. Call me if you need anything. We have a peer support program that the greatest thing about this webinar is that it should never end when that person leaves that department. It should, encompass all the public safety realm, which is great. But, at the end of the day, it's super important. We need to take care of each other. And one of the things that concerns me is that, the hospitals do a good job with their EAP programs. But the reality is they don't want to talk to somebody that's just doesn't understand what we do.
Yeah.
It's really vitally important that they can engage with folks that actually understand what we've been through. And to me, this is so overdue and so important, whether it's firefighter, police, EMS, but physicians, we're horrible patients. We feel like, we all have superpowers, but, the job is hard. We all have lives outside of the hospital. And sometimes our peer support folks are dealing with our clinicians and it has nothing to do with work, something going on at home, a divorce, some financial hardship, a death in the family. So the fact that they know that those people are there are vitally important. So kudos to you guys for doing that.
Yeah.
Thanks, I appreciate it.
Great
Thanks,
comments.
It's great to see you. And thanks for the kind comments, my friend. Great to see you.
Got it, buddy. Keep it up.
Thank you.
So Steve, comment on my comment and Brett's comment, and then we'll try to wrap it up. But what are your thoughts on that, and how departments who are not doing this should restructure to do that? What are your thoughts on that?
Well, I think what he said was very correct. People want to talk to somebody who understands. What peer support can offer. We are the people who understand. We've lived the job, we've done it, we've gone through personal things, this or that. We can act as that bridge to EAP. I'm very fortunate in the way our EAP is structured. It's not a typical EAP. It's called an EAP, but it's very different. But even if we were working within a structured EAP, and I do with some of our employees, the fact that I have made connections with those EAP and I can talk to them and explain to them what's happening. Now that goes both with EAP and with the person that I'm working with from the department, and I can help bridge that. I can explain what it looks like to go sit there, how I do it, how I have done it. And that real world experience and that ability to connect to people really is clutch.
Yeah, it's huge. Okay, very good. Well, listen, there's so many aspects to this issue, and Brett brought it up, Wayne brought it up, Steve has brought it up, Charlie, and I think that this obviously deserved much more than 30 minutes. But Charlie, I'm going to give you the last word. I mean, you've been working at this for a long time, and I don't want people to think that this is just that this just happened overnight. What would you recommend would be the next 2 steps? Maybe even 1 to 2 steps that people should take at their locality, at their local, organization to start moving in the right direction from after what you've been through and now that you have the 2020 hindsight.
Yeah, I think you've got to be really genuine in your approach. I think people have to trust you. I think they need to know that if they make a mistake, it's okay. I think they need to know, because that does correlate. If you make a mistake on a call and, you talk them through that call and you support them when they're down, that does correlate and coordinate to later on when they have stuff in their personal life. So, they might not come to me, but they might go to Steve. I prefer them to go to Steve, but I'll always answer their phone if they need it. So if they call me, they're going to get me, but they have to believe in that, because if they don't believe in the system, or they believe that their confidentiality is being breached, then they don't want to be a part of it. So that's number one. You got to love on your people, because they're the ones that do the tough job every single day. And then number two is you really have to work with your hospital staff. This was Delray Medical Center basically shut down a conference room. The CEO has worked probably, over a week solid, over 40 hours on this with us. And her leadership by bringing everyone to the table wasn't just because she wanted her name on the billboard. She didn't want her name on the PowerPoint presentation. It's because she genuinely cares, and she believes in what we're doing. She believes in supporting the community, and she believes in our partnership, our relationship. But that's because during Blue Skies, we do all those hard things and have those continuous conversations, because on Grace, guys, we're set up. So love on your people, build your relationship, and be there for them, and be honest. They can sift through the BS quickly. And listen, I'll be honest with you. I have a physician too, a friend of mine, that's going through some hard times right now. And we have conversations late at night because he's a personal friend of mine, and I check on him and I care about him. So, it doesn't have to be, you have to be the chief, you have to be the doctor, doesn't have to be that you're the nurse. And it's, take all the badges, take all that stuff out the window, and just, treat people the way that you would want to be treated if you were having a bad day.
That's great. Well said. Let me bring in Dr. Parmar. Janil, go ahead. I see you have your hand raised. Welcome, and thanks for joining us, and let's hear your question.
Yes, sir. Sorry about the late question. Chief Coyle, it was a great seeing you live give this presentation last week at the luncheon. It was a pleasure meeting you. I just wanted to ask you if someone shows up at one of our first responder, or in our network, if they show up at a different hospital, how could we get them into Delray? How could we sort of pipeline them into this program?
Dr. Palmer, great to see you, my friend. Great to hear your voice. And you know what? That's a phenomenal question. So I definitely would have to work through with that. But I guarantee you, if we got Delray and all of the other networks together to talk about that, I guarantee you that there's a way that we can do it, and we could probably do it very discreetly too, where if there was a transfer, that it was something that was done low key, right? And it wasn't that really drew up a bunch of red flags. But I'm sure they would be willing, once they're inpatient care, there has to be a transfer. I know you guys know that much better than I do. So I think what we can do is have a conversation. How do we limit all of the hurdles in that transfer? And how do we do it discreetly? So I would love to hear more. I would love to talk to you and figure out what is that process. Do we bring it to the ER physicians, or do we bring it to the CEOs and say, hey, how do we make this where our networks all work together to make sure that the first responder gets that space and care they deserve?
Excellent.
Absolutely. Thank you.
Great question. And I really appreciate everybody. Great topic. We got to continue the conversation. Personally, I would like to, and I did a webinar yesterday with another person who was on a podcast, 𝐁𝐮𝐢𝐥𝐝𝐢𝐳, as you guys, many of you know, has been fighting for this for a long time. And the topic I would also like to talk about are all the other therapeutic options. And I know that at Palm Beach County and in Coral Springs and other places, people have ketamine as an option. There's psilocybin, there's MDMA. And I think that there's so many avenues that this will expand to. But the fire department needs leadership like Chief Coyle, like Chief Kennedy, like Steve Newell, to actually make sure that our folks are protected and that we care about our own people. So great webinar. Let's continue the conversation. And Chief, thanks for knocking it out of the park for us this week. Really appreciate you.
It's an honor to be here, and it's so great to talk to everyone. So thank you for allowing me the opportunity, and hopefully this group duplicates the process for your people, because they deserve it.
And thanks for sharing all the documents. R&D, baby, R&D.
Always.
Yeah. So all right, the link to Dr. Pepe's webinar is in the chat. He's going to be talking about a few cool topics today, so might as well join that one as well. Claim your CME, and we'll see you guys next time. Thank you.